we have understood that the introduction of the new technologies like ultrasound can make more efficient, more accurate those evaluations that traditionally have been performed clinically. So the midwife can use ultrasound to determine the progression of labor, the diagnosis of the fetal head level in the birth canal, the diagnosis of the fetal position, with a level of precision which is higher compared with what they can do just base this evaluation on their clinical skills and experience. And more importantly, it has been demonstrated that women tolerate much better ultrasound examination in labor ward that is not invasive, is not intrusive like clinical examination, is based on a ultrasound scan with the probe which is placed on the maternal abdomen or on the external part of the perineum without entering the vaginal canal. So this type of assessment, besides giving more precise data and information regarding the clinical progression of labor, is also associated to a higher satisfaction from the woman. And let me say another more important point, there are data that have recently shown that in women that are assessed thanks to the use of ultrasound, rather than being submitted to repeated clinical examination, also the risk of incurring in infection in labor is lower. So I really see that adding this new tool in the professional armamentario of the midwife in pregnancy, but especially in labor ward, can give a more sustainable way of producing an efficient and more, let's say, more favorably accepted care provided to the woman from the midwife themselves in labor wards. Point-of-care ultrasound is a topic that has emerged in the last years as a very useful and innovative approach that can reinforce our clinical assessment of a patient thanks to the use of usually portable machine. We can add some information coming from ultrasound to our clinical information coming from the standard assessment. I see a point-of-care ultrasound in labor ward as an extraordinary opportunity to improve our ability to diagnose, identify abnormal finding, especially in cases where the labor course is low or is abnormal, rather than trying to reach a diagnosis using some traditional tools like our clinical examination, which have been demonstrated to be poorly accurate, and especially when repeated examinations are needed, poorly tolerated by women. Adding point-of-care ultrasound to our standard assessment may increase the sustainability and the efficiency of the intrapartum care that midwife and in general birth attendants may provide to our laboring patients. Important question. I've partially touched this point in my previous answer, I'm quite sure that the data on this particular aspect will become stronger and stronger in the future. It has become quite clear, and there was a randomized control trial that has proven that especially for women that need repeat examination due to a slow progress of labor, if we replace serial vaginal examination with external ultrasound assessment, we may decrease the negative effects of the contamination of the birth canal, and we may decrease the incidence of infection, the incidence of chorioamnionitis, and we may also increase the engagement of the woman that will feel and usually refer to be to tolerate much better an ultrasound examination, which is same to define the fetal head position, station, and progression, rather than receive multiple and serial clinical examination, which may increase their discomfort and, as I say, pose this woman at higher risk of infection. I would say that especially in the second stage of labor, there are nice data coming from some centers showing that when the woman feels to be exhausted and less motivated to go on with active pushing, doing if the midwife does an intrapartum ultrasound and shows to the woman on the screen the fetal head and how it progresses out under maternal pushing, this increases further the motivation of the woman that will see the fetal head of the baby going down and will be so positively impacted by this. This has been shown to reduce the time needed to complete the second stage of labor and to facilitate the fetal head descent without increasing the risk of adverse outcome. The connection between the world of obstetrician and the world of midwives is vital, not only in terms of the quality of care which is provided in pregnancy and in labor wards, but also in terms on how this steady connection between these different figures who are in charge of the pregnancy management can help in promoting the right models of good behavior in pregnancy and in preparation to labor and delivery, in the postpartum. So I think that not in all clinical context and geographical context, the connection, the fusion of vision between obstetrician and midwife has been so strong and solid. I think that thanks also to create a common background in terms of tools and facilities can even make stronger the fusion between these two figures, and this can contribute also to the external images, how this group of birth attendants is perceived by the woman when they are approaching to the maternity because they are pregnant or because they are expected to be delivered. Yeah, just to answer to this last question, I would say that the role of ISUOG is fundamental, because thanks to workshop, courses, and the opportunity to involve midwives in events where we can have some theoretical lectures, but also some hands-on and practical part of the courses using simulator. There are now a new generation of simulators for labor and delivery, which are also suitable for the ultrasound examination. So making the opportunity of meeting and sharing experience between midwife and obstetrician more frequent within a society such as ISUOG that would say is the leading society in the world of obstetrics ultrasound, can be the right approach in order to make closer these two worlds, these two communities, and create, in my view, the new figures of the midwife of the next century. The midwife that is not just the figure of the birth attendant using preferentially the hands for the maneuvers, but using as the new obstetrician, the new generation obstetrician, with the same accuracy and experience and competence, the hands and the ultrasound, approaching the ultrasound, of course, when they are needed. If there is no clinical indication, there's no sense of doing that, but having the competence and the ability of putting these two tools together, knowledge, clinical experience, but also ultrasound, in order to ensure the best care that is possible for the woman who is seeking assistance. I hope that this would be the basis to involve the midwife in our society, creating special courses and workshops when they are involved as the primary leads of this type of events. And hopefully from the next World Congress, we are trying to create the first session on intrapartum ultrasound where the midwife will be possibly involved as speakers. This can be the new start of a new era where the midwife will be, as I said, among the leading figures using ultrasound in the management of pregnancy and especially in the management of labor.